So today's topic is ventilator-associated pneumonia. Those who have the textbook, please mention the page number in the chat box. I don't have the textbook on me. Ventilator-associated pneumonia. So what is it? In short, it is called VAP. Okay, ventilator-associated pneumonia. It's a complication of the mechanical ventilation and is defined as the occurrence of pneumonia in patients who are undergoing mechanical ventilation. Okay, for at least 48 hours. At least 48 hours they were put on ventilation and suddenly pneumonia started or an infection started. Okay, after being put on ventilation, infection started specifically within 48 hours. Okay, before that, there was no infection. So how does it happen? Usually it happens by aspiration of bacteria that usually you will find in your oropharynx area. Okay, oropharynx area, there are certain bacteria, okay, that the person may aspirate. It goes into their trachea, okay. Or sometimes if their abdomen is full and if there is a regurgitation, okay, the contents of the stomach can go back into the trachea. That can also cause aspiration, okay? And that would lead to pneumonia. So usually it is aspiration of either the bacteria or the contents of the GI tract that is leading to ventilator-associated pneumonia, okay? So it's a pneumonia that develops more than or equal to 48 hours after any endotracheal intubation is done and mechanical ventilation has begun for the patient. After that, when a pneumonia takes place, that is what we call as ventilator-associated pneumonia. Okay. And sometimes microaspiration of secretions which are around the endotracheal tube cuff, okay, that can also lead to this pneumonia. And if the patient whose immunity is also impaired because of long-term sedation, critical illness, supine position, because of all these factors, if a person's immunity is also impaired, that could also put them at the risk of pneumonia. So also there are certain risk factors associated to it. A person who is on ventilation, mechanical ventilation for more than 5 days, okay, the risk increases. Supine positioning, okay, that can also increase the risk. Not performing adequate hand hygiene by the healthcare workers. And when you are suctioning, you are removing the secretions, your techniques are not good. Re-intubation, once the intubation was done, it is removed and re-intubation is done. That can also lead to pneumonia. And too much of antibiotics was being used for a very long term. Before and after the person is on ventilator, a lot of antibiotics has been used. Okay. NG tube feeding was done with aspiration. There was a history of aspiration because of NG tube feeding. Age, people who are of a certain age, elderly patients, and who already have other disease conditions like pulmonary tuberculosis, any respiratory issues, cardiac issues, okay, peptic ulcer, gastric issues, regurgitation issues. These are already there. A person has a lot of comorbidities. They are also at the risk of developing pneumonia, okay, ventilator-associated pneumonia. So hand hygiene prevention, the first fact is make sure you follow strict hand hygiene and infection control in the hospital. Healthcare workers should always wear a mask, gown, whenever soiling of respiratory secretion is anticipated. You know that when you go near to the patient, you can expect the respiratory secretion. Protect yourself, okay? Elevate the head of the patient to 30 to 40 degrees. That elevation should be there. It prevents aspiration usually. Remove devices as soon as indicated. As soon as the physician suggests that the patient can be out of ventilator, immediately remove it. If the patient has been suggested to be out of central line, immediately remove it. Perform orotracheal rather than nasotracheal unless it is contraindicated. Always the first option should be orotracheal intubation. Only if it is contraindicated, go for nasotracheal intubation. Always use non-invasive ventilation whenever possible. Okay, non-invasive ventilation whenever possible. That is ampu bag, oxygen therapy. Okay. And reduce the duration of ventilation as much as possible. Don't put the patient on ventilation for a very long time. Okay. Avoid histamine receptor blocking agents, that is antacids, proton pump inhibitors, especially for people who are not at the risk of peptic ulcer, stress ulcers. If the patient does not have peptic ulcer, stress ulcers in their stomach, there is no requirement of putting histamine receptor blocking agents, that is a Rantac kind of medicines, okay? Proton pump inhibitors and all. This will reduce the acidity, okay? But avoid it because you need the stomach to be acidic to take care of the microorganisms. If the stomach is not acidic enough, microorganisms will colonize the stomach and put the patient who is in ventilator at more risk of developing pneumonia. Okay. Regular oral care has to be done with antiseptic solution. Okay. Healthcare workers have to give this oral care for intubated patients. Avoid gastric over distension and all. That is, when you are giving NG tube feeding or any form of feeding to the patient who is in ventilator, do not overfeed the patient so that the stomach is distended. Okay, that could, if the patient coughs or something, high chances of regurgitation is there. Okay, so don't over distend the stomach by overfeeding. Remove condensate from ventilatory circuits only when it is visibly soiled. Otherwise, no need to tamper the ongoing ventilatory circuits. Only when the condensate is visibly there, you can see the condensate forming in the tubes, within the tubes. Only then remove the tubes and change the tubes. Otherwise, there is no requirement of changing the ventilatory circuits. Store and disinfect respiratory therapy equipment properly. After every patient has been used, properly wash, clean, manually clean. Okay. Then disinfection is done, high level disinfection is done, and then it is dried and stored in a dry environment, closed dry environment. So remove the condensate only when it is visibly soiled, and after cleaning the ventilatory circuits and respiratory therapy equipment, cleaning has to be done manually, drying has to be done, high level disinfection has to be done, dry it, store it in a closed dry area. Okay, it should not be open and moist. Educate the healthcare workers and develop surveillance systems so that you can catch these infections as early as possible before it is forming. And usually when you do the oral care, use chlorhexidine solution. Chlorhexidine solution should be used as an antiseptic for oral care. So far, is it clear to all regarding the ventilator-associated pneumonia? Any doubts? Treatment, you have to put the patient on antibiotics based on the local antibiogram. Okay, whichever antibiogram is used in the hospital, based on that, the patient will be put on antibiotics for this. Okay. And once the patient's sputum culture is available, based on that, antibiotics should be used. Usually 7 days treatment will be ongoing for ventilator associated pneumonia. Any doubts regarding ventilator associated pneumonia? Next is central line associated bloodstream infection called as CLABSI. Okay. And this is a laboratory confirmed bloodstream infection in patient who has been put on central line. Okay. Within 24, within 48 hours after being put on central line, a bloodstream infection began in the patient. Okay. And there was an onset of symptoms as well. And that confirms the CLABSI, central and associated bloodstream infection. Okay. That is the definition of CLABSI. So what to do to prevent this? Again, it's the same. Hand hygiene is strictly has to be done before insertion. During any manipulation, if you are going to touch the central line as well, hand hygiene has to be done. Without hand hygiene, without following proper aseptic techniques, do not touch the central line as a healthcare worker. Okay. Aseptic technique should be followed during insertion and even during care. Okay, whenever that antiseptic solutions and care wound care is given around the central line, aseptic technique has to be followed. Maximize the sterile barrier precaution during catheter insertion. Okay, that is for the healthcare worker as well, not just for the patient. The healthcare worker also has to put on the personal protective equipments before insertion, catheter insertion. Strictly follow catheter site dressing regimens every 3 days, every 72 hours, once a week, based on what type of dressing you have used for central line. If it is the transparent dressing, adhesive transparent dressing, once a week is fine. But if it is gauze piece dressing, just a second. But if it is a gauze piece dressing, then every 3 days you have to, just a second. So based on what type of dressing you have chosen for the patient, based on that, regimen has to be followed. If it is the transparent adhesive dressing, once a week is fine. But if it is the gauze piece dressing that you have used, every 3 days it has to be changed. Okay. And always select the insertion technique or insertion site which has the lowest risk of complications. For example, if I give you two options, the femoral root or the subjugular clavicular artery, femur artery or the clavicular artery, which one would you choose for central line? Which has the lowest risk or complication? It's the clavicular, subclavicular line, okay, not the femoral. If there is some wound or if the clavicular line is infected, only then you can go for the femoral line. Otherwise, clavicle is the first option. Okay. Avoid femoral vein for adult patients as much as possible. Use subclavicle vein in adult patients. And when it is no longer essential, as soon as the doctor has declined, has mentioned it is no longer required, immediately remove the central line. You don't have to routinely replace the CVC just because you want to prevent infection. That is not the right way. Okay. Every 2 days, every 3 days, you are repeating the central line procedure, insertion and all, just to prevent infection. That is not the right way. Okay. Once it is inserted, due diligence have to be followed to prevent infection. Okay. No need to replace the peripheral venous catheter more than 3 to 4 days. Okay. Every 3 to 4 days, you can replace the venous peripheral PVC lines, okay, not the CVC, PVC. But for kids, you can leave it in place as much as possible, even beyond 4 days, 5 days, 6 days. For children, you can keep it because it is very difficult to find the veins in kids and they move a lot, okay? And once it is secured, use it as much as possible, okay, for kids. Until and unless there is complication, no need to frequently replace the PVC in children. And also develop surveillance system for central line associated infection as well. Treatment again, same, antibiotics immediately. If you have to test for MRSA first, if it is a MRSA case or not, test for it. Okay. Gram positive, negative bacilli, what it is, gives that particular antibiotic. Okay. And add antifungal medications as well if it is a high risk patient. And what are the conditions in which you have to remove the catheter? If there is a situation of severe sepsis, okay, bacteremia, septicemia, okay, in fungal infection, in these kind of situation, you have to remove the central line, okay, and adjust the antibiotics as per culture and sensitivity. As soon as the patient's blood reports come, you have to identify what kind of bacteria has infected the patient, use the antibiogram, and antibiotics should be prescribed. This is for doctors, okay? And once the culture changes, sometimes the patient's fever or infection does not go away directly, okay? The number of causative agents may decline. So accordingly, you have to change the antibiotics. Usually, 7 to 14 days, the patient will require treatment to overcome this infection. Okay. Blood cultures are taken from the catheter and also from the vein, okay, which has been infected. From this area, blood culture is taken. So that's all for CLABSI. If you have any queries, you can mention.